In today's video, we will discuss about the clinical utilization of various antacids. We all know there are numerous medications available for stomach acid suppression. For example, H2 blockers, proton pump inhibitors, and numerous antacid syrups, as well as few of the newer medications. So, it is very helpful to know which medication should be used in what particular condition. So, as mentioned, we all know mainly there are H2 blockers, proton pump inhibitors, and the newer medications, that is PCABs, potassium competitive acid blockers. So the full form we have to remember, because these are the newer group of medications in antacids. So PCAB stands for potassium competitive acid blockers. At present, the most promoted among this group is vonoprazan. So we'll deal all of these. First, we will see what are the differences between all these three groups. So when it comes to mechanism of action, we know that H2 blockers are the competitive antagonists for H2 receptors, whereas proton pump inhibitors will inhibit proton pumps by binding covalently, and this action is irreversible. So what is the meaning of irreversible action? Once they bind to the proton pumps and once they inactivate these pumps, this action will be irreversible, in the sense, unless the new proton pumps are generated, which usually happens during night time and takes minimum 24 hours for the regeneration of proton pumps. So till that time, these medications will be acting. That is the meaning of irreversible blockage. PCABs are the reversible potassium competitive inhibitors. So these are the mechanism of action we have to know. Coming to the onset of action, here H2 blockers, for example ranitidine, they will have rapid onset of action. So once taken, they will start their action within 30 to 60 minutes. Whereas the classical proton pump inhibitors, they will have slight delayed onset of action. Actually, they will require 2 to 5 days for the onset of their proper action. Whereas the newer medications also have rapid onset of action. Why is it important? Because in acute conditions where the individual is suffering with acid related complications, and whenever we need rapid suppression of stomach acid, we have to either go ahead with H2 blockers or the newer medications, because PPIs will take their own time for the onset of action. Next important thing is related to the meal dependency. So how is it related with the meal intake? H2 blockers are not dependent on the meal. In the sense, we can advise these medications before food or with the food. So it doesn't matter in their mechanism of action. Whereas for PPIs, meal timing is very strict. In the sense, you might be knowing already, these medications should be taken minimum 30 to 60 minutes before taking meals, because on empty stomach, when these medications are given, whenever there is concentrated acid in the stomach before meals, it is easier for these medications to get activated, because these are prodrugs. So they need stomach acid for the activation. And as mentioned, their onset of action will take little bit time. So during that time, after 30 to 60 minutes, when the individual takes meal, then the proton pumps will be in the active mode for the secretion of acid for the digestion of taken meal. So these active pumps will be inhibited by now activated proton pump inhibitor medications. They will be in the prodrug form. So if taken before meals, in the concentrated stomach acid, they will get activated and they will be ready for their action. So once the individual takes meal, proton pumps will be activated. So these activated proton pumps are the targets for the activated proton pump inhibitor medications. So this is the mechanism of action. That's why if these drugs are taken with meals, the proton pumps will be already activated, but there will be failure for the conversion of PPIs from prodrug to the active drug. So their action will not be seen. Whereas PCABs, again, these are not related with the meal intake. So any time before or during or after the food, we can advise for these medications. Next feature is about the tachyphylaxis. So it is commonly seen with H2 blockers, in the sense, if you keep on giving these medications for 1 to 2 weeks, after that the receptors will not respond to the medications. That is nothing but tachyphylaxis. So commonly these are for very short period of time we can utilize these medications just because they have high risk of tachyphylaxis. Whereas this feature is not seen with PPIs as well as PCABs. That's why we can use these drugs for chronic acid suppression. Coming to the next feature, that is nocturnal control. As you all might be knowing, majority of the acid pumps will be highly active during night time, and some of the behaviors such as recumbent position, the natural physiology of increased acid production during night time. So all of these mechanisms will lead to the aggravation of symptoms during night time. So whatever medications we are giving, it has to suppress that nocturnal symptoms as well. So it is very excellent when it comes to H2 blockers. So if these medications are given during evening hours, they will be very good at suppressing nocturnal symptoms. But again, we have to keep tachyphylaxis related thing whenever we are planning to use H2 blocker. So the benefit will be of very short term. Whereas PPIs, the nocturnal control is poor. Mainly, as you all know, the drug will be given only once a day, usually once a day, and generally it is suggested to take in the morning, 30 to 60 minutes before breakfast. So that action, usually we can say it will last for 24 hours, but at the end of this action time, there will be again regeneration of the newer proton pumps. This irreversible action, whatever will be there, at the end of this particular action, there will be again regeneration. We will not be sure during night time when these proton pumps are regenerated. That's why there will be re-emergence of the symptoms during night time. So we can say nocturnal control is quite poor. So what we can do for this? We can advise to take this particular medication during evening hours, or else we have to choose some other group along with the PPIs for nocturnal symptoms control. And here I want to tell you one more commonest mistake we can say. Few people will give PPIs, not just OD, they will suggest to take these medications BD. It is totally impractical because, as mentioned, once the proton pumps are irreversibly inhibited, for the next generation of newer proton pumps, the time taken will be 24 hours. So definitely the first dose might have inhibited the already existing proton pumps. So after 12 hours, during night time, even if you suggest one more dose, it is of no use because there are no active pumps to get inhibited. That's why these drugs should be advised only once a day. When it comes to PCABs, they are very excellent and they have sustained results when it comes to nocturnal control. And the final feature to be discussed is regarding the enzymatic action, that is cytochrome P2C19 impact on all of these medications. So it is not seen with H2 blockers, whereas probably you all might be knowing PPIs have significant impact on this particular enzyme, so they will have drug interaction, especially if the individual is on antiplatelets such as clopidogrel or some anti-seizure medications. So that point we have to remember. If there is history of usage of anti-epileptic medications or clopidogrel, you have to be careful when you are choosing PPIs because of the drug-drug interaction. And this is not seen with PCABs. So this slide is very, very important. I can tell you have to take the screenshot and attach this particular slide so that you can repeatedly have an eye till you become expert in knowing all these points related to antacids. Next, we can focus upon the correct dosing strategy. Here, mainly we have to know about the interaction of proton pump inhibitors and the commonest used antacid syrups. So remember, always first we have to advise the individual to take PPIs 30 to 60 minutes before meal, because as mentioned, it requires active proton pumps and an empty stomach for their action. Whereas antacid syrup should be advised 1 to 2 hours after meals or right before bedtime for immediate symptom relief. So why this time gap should be maintained? Because just remember, if you give both of these together, these antacid syrups will form a covering or a coat in the stomach, leading to the non-availability of acid for the activation of PPIs. So PPIs will not get activated because these antacid syrups will form a coat and they will raise the gastric pH very rapidly. So this raised pH in the stomach leads to the premature dissolution of the PPI capsule, again making this particular drug ineffective overall. So just remember, don't prescribe both of these together because it will inhibit the activation of PPIs. Also, it will act as a barrier for the action of PPIs. So both of these should be separated, and this antacid syrups are the rapid relief. So whenever the individual is having severe symptoms and you are targeting rapid relief, otherwise just before bedtime, if the individual is having excessive nocturnal symptoms, then only we can advise for antacid syrups, and it should be advised to take 1 to 2 hours after meals. So these points are very important. Coming to various proton pump inhibitor medications, the commonly used ones are being discussed here. Rabiprazole, which has good potency when it comes to its action, and remember, R for rapid. So among PPIs, this particular medication has rapid onset of action. Also, there is very low risk of interaction with other medications which gets metabolized with this particular enzyme. So overall we can say fast onset of action with minimal drug interaction, but when it comes to potency, we can say it has some standard potency. So we can choose rabiprazole as the go-to PPI whenever we are thinking of utilizing this particular group. When it comes to pantoprazole, remember P for polypharmacy. Why? Because this has very minimal interaction with other medications like clopidogrel. So when an individual is on those particular medications, if you want to choose one PPI, we can go ahead with pantoprazole. Whereas esomeprazole and omeprazole, these medications are dependent on the cytochrome P 2C19 enzyme for their metabolism. That's why they have higher risk of drug-drug interaction. This point has to be remembered for esomeprazole and omeprazole. And for entrances, just remember the PPI with longest duration of action is dexlansoprazole. And as mentioned in previous slides regarding H2 blockers, tachyphylaxis should be remembered always. That's why this drug cannot be used for more than 2 weeks. So only for short duration of action, this is a good drug. Otherwise, it will lead to tachyphylaxis. Coming to the limitations of PPIs, we know that it needs to be activated. For that, it needs stomach. So if taken with food or with some other antacids like H2 blockers or antacid syrups, this drug will not be activated. And as mentioned, it has very poor control of nocturnal symptoms. Why? Because PPIs bind only to actively secreting pumps, and new pumps will get generated overnight. So patients frequently suffer nocturnal acid breakthroughs. Coming to the newer medication, that is PCABs, which is in talk nowadays everywhere, mainly vonoprazole drug. Remember few points. It has very high affinity and potency as well, in the sense it can maintain the gastric acid suppressed by maintaining pH of more than 4 for up to 24 hours. So sustained action we can say, and there is no relation with the meal timings, as well as it is effective for severe erosive esophagitis. Even grades such as C or D, these drugs are significantly beneficial. And in clinical trials, it has been proven to have superior H. pylori eradication. So whenever there is non-response to other group of antacids, we can start practicing with this newer group of medications, that is PCABs. So overall, in summary, we can say whenever there is immediate symptom relief requirement or intermittent nocturnal breakthroughs, we have to choose with H2 blockers or other antacid syrups, we can say. And if the individual is already taking some other group of antacids, both of these should be separated by minimum 2 hours. And for chronic maintenance therapy or if the individual is on polypharmacy, always go ahead with PPIs. This is the standard practice everywhere. Whereas if the individual is having severe disease or for refractory cases, try with the newer medications, that is PCABs, vonoprazan. So hope you have understood these commonest used antacid medications. We can consider this as very important concept in clinical practice, because without knowing the details of various groups of antacids, we can't suggest the patients regarding these medications. So I hope you have got a clear concept regarding various groups, when to use them, what points to be kept in mind when we are choosing various medications. So if you find it useful, share it among your friends, colleagues and all. And also don't forget to subscribe our channel for more of such clinically useful medical videos. See you in next video. Till then, take care. Thank you.